Nursing care of serious mental illness across the continuum. Module 1, Schizophrenia and Perceptual Disturbances. When we talk about perceptual disturbances in psychiatric nursing, we are most often talking about schizophrenia and related psychotic disorders. Schizophrenia is a chronic psychotic disorder that affects thought processes, perception, emotional responsiveness, and behavior. In other words, it changes how a person experiences and interprets reality. It's important to understand that schizophrenia presents with a range of cognitive, behavioral, and emotional symptoms. There is no single symptom that confirms the diagnosis. Diagnosis requires a constellation of symptoms over time. For formal diagnostic language and definitions, please refer to Appendix J in your syllabus. Schizophrenia affects approximately 0.3 to 0.7% of the global population, so less than 1% worldwide. Although relatively rare, it accounts for a disproportionate amount of disability and healthcare utilization because of its chronic and severe course. The illness is defined by a disturbance that lasts at least 6 months and significantly impairs functioning in work, relationships, concentration, and self-care. From a neurobiological perspective, schizophrenia involves abnormal brain development and neurotransmitter dysregulation. Increased dopamine activity in the striatum plays a central role in positive psychotic symptoms. However, the disorder is more complex than dopamine alone. Glutamate and GABA systems are also involved, particularly NMDA receptor dysfunction and cortical circuitry disruption. What you need to understand clinically is this: these neurochemical imbalances converge to produce psychosis. For NCLEX purposes, you must know the DSM-5 diagnostic criteria. 2 or more symptoms must be present for at least 1 month, and one of those must be delusions, hallucinations, or disorganized speech. There must also be functional decline and continuous signs of illness for at least 6 months. And always remember, you must rule out mood disorders with psychotic features, substances, and medical conditions. Symptoms of schizophrenia fall into 3 major categories: positive, negative, and cognitive. Positive symptoms are distortions of normal function, hallucinations, delusions, disorganized thinking, and abnormal motor behavior. Negative symptoms reflect a loss of normal function, reduced emotional expression, decreased motivation, and social withdrawal. Cognitive symptoms affect attention, memory, processing speed, and executive functioning. These are often overlooked, but they significantly impact daily life. Hallucinations are sensory perceptions that occur without an external stimulus. They may be auditory, visual, tactile, olfactory, or gustatory. Auditory hallucinations are the most common in schizophrenia and may involve voices commenting, conversing, or giving commands. Here's what I want you to remember as nurses. Hallucinations are very real to the patient. The emotional response is real. The fear is real. Emotional stress can intensify hallucinations. Grounding techniques, redirection, and structured engagement can help reduce internal stimulation. For NCLEX and for safety, always assess command hallucinations directly. Ask, what are the voices telling you to do? This is not optional. This is a critical safety assessment. Delusions are fixed, false beliefs that are not culturally supported and persist despite evidence to the contrary. Common types include persecutory delusions, delusions of reference, delusions of control, grandiose delusions, somatic delusions, and religious delusions. Do not debate delusions. Do not try to prove the patient wrong. Your role is to acknowledge the emotional experience, maintain safety, and gently present reality. Negative symptoms are often more disabling long-term than positive symptoms. They represent diminished emotional expression and reduced motivation. Remember the 5 A's: affective flattening, alogia, avolition, anhedonia, asociality. These symptoms may resemble depression, but they are core features of schizophrenia and significantly impact recovery. Cognitive symptoms interfere with independent living. These include impaired attention, working memory deficits, executive dysfunction, slowed processing speed, and difficulty completing tasks. Cognitive impairment affects a patient's ability to maintain employment, follow treatment plans, and engage meaningfully in recovery. As nurses, this influences how we communicate and structure care. Disorganized thinking frequently presents through observable speech patterns, and it is expected that nurses recognize and correctly identify these symptoms for both clinical practice and NCLEX preparation. You must be able to distinguish looseness of association, tangentiality, circumstantiality, flight of ideas, word salad, neologisms, clang associations, thought blocking, and concrete thinking. These are not random communication errors. They are diagnostic indicators that guide assessment, safety planning, and clinical decision making. Your ability to identify these patterns reflects critical thinking and strong psychiatric nursing assessment skills. For precise language and definitions, please refer to Appendix J in your syllabus. Motor disturbances may include echopraxia, waxy flexibility, catatonia, or ataxia. Catatonia requires careful monitoring because it can lead to dehydration, malnutrition, or medical complications. Safety is always your priority. When interacting with a psychotic patient, remain calm, steady, and non-judgmental. Use short, clear statements. Validate the emotional experience without reinforcing the psychosis. For example, I understand that the voices feel frightening, rather than agreeing they are present. Then gently present reality. I do not hear the voices, but you are safe here in the hospital, and we are here to help you. Do not argue. Do not challenge. Use the acknowledge and redirect approach. Redirect to structured activity or grounding when appropriate. Safety first, always. Nursing interventions should focus on reducing environmental stimuli to minimize sensory overload and anxiety. Maintain appropriate physical distance and avoid sudden movements. Touch should be avoided unless absolutely necessary, as psychotic patients may misinterpret physical contact as threatening or controlling. If touch is required for a procedure, the nurse must clearly explain what will happen, ask for permission, and provide rationale before initiating contact. Continue to monitor closely for suicide risk and potential violence towards self or others. Use short but frequent interactions rather than prolonged conversations to prevent overstimulation. Always maintain awareness of room positioning and exit routes to ensure safety for both the patient and staff. The overall goal is to promote safety, preserve dignity, reduce anxiety, and gently anchor the patient back to shared reality without confrontation or escalation. From a nursing perspective, comprehensive assessment is non-negotiable. Suicide risk must be assessed directly. Approximately 5 to 6% of individuals with schizophrenia die by suicide, and many more attempt. Ask clearly, are you thinking about killing yourself? Do you have a plan? What are the voices telling you to do? Risk increases with depression, hopelessness, substance use, early illness course, recent discharge, and poor adherence. Nursing interventions include presenting reality without confrontation, maintaining structure, reducing stimuli, reinforcing medication adherence through teaching, and supporting evidence-based psychosocial interventions such as CBT for psychosis, family psychoeducation, coordinated specialty care, and supported employment. Stabilizing a patient with schizophrenia using pharmacologic treatment is rarely simple. While many patients respond to a single antipsychotic, some continue to experience residual or treatment-resistant symptoms, and approximately 1 in 4 may be exposed to antipsychotic polypharmacy. Although sometimes used in complex cases, polypharmacy increases the risk of side effects and may contribute to higher mortality. For NCLEX preparation, nurses must assess for non-adherence, inadequate dosing, and side effects, while also considering individual patient factors such as preferences and long-term recovery goals. At the same time, they monitor treatment effectiveness, provide ongoing education, reinforce adherence, and coordinate care across settings. Antipsychotic medications are foundational, but remember, psychosocial interventions are essential for long-term recovery. For a deeper discussion of medication classes and mechanisms, please refer to the Psychopharmacology series. Schizophrenia is complex and chronic, but it is treatable. Your ability to recognize DSM-5 criteria, assess safety, understand positive and negative symptoms, communicate therapeutically, and support evidence-based care directly impacts patient outcomes. While much of our discussion has focused on acute psychosis and stabilization, it is important to remember that schizophrenia and related disorders are chronic conditions. Many individuals living with schizophrenia fall under the category of serious mental illness, or SMI, requiring long-term coordinated care beyond the hospital setting. Recovery does not occur in isolation. It requires interdisciplinary collaboration and community engagement. In Module 2, we will shift our focus from acute recognition and treatment to community mental health systems and the recovery model. We will examine how nurses contribute to long-term stabilization, advocacy, care coordination, and recovery-oriented practice within the community setting. Because in psychiatric nursing, our responsibility does not end at discharge. It continues across the continuum of care.